I'm going to turn it now to our final speaker, Dawn Godbolt, who is the policy director at the National Birth Equity Collaborative, where she focuses on federal policy. She also sits on the National Quality Forum's Maternal Mortality and Morbidity Committee and chairs the Equitable Maternal Health Coalition Policy Working Group. So Dr. Godbolt, we'd be delighted to welcome you.
Thank you so much. Good afternoon, everyone. I'm Dr. Dawn Godbolt, the Policy Director at the National Birth Equity Collaborative, and my presentation today will discuss how NBEC is working to address the Black maternal health crisis through policy and practice at the federal policy level. Next slide. The National Birth Equity Collaborative is a Black woman-led advocacy organization that provides solutions to the maternal health crisis for Black women by Black women. The policy shop at the National Birth Equity Collaborative uses a reproductive justice lens to advise elected officials, key stakeholders, and community-based organizations as we strive to advance birth equity through policy, practice, and programs. In the next couple of slides, I will share with you how NBEC advocates for Black women across the country in an effort to address the ongoing maternal health crisis. Next slide. A thank you to Dr. Taylor for explaining the tenets of reproductive justice. This is the same frame that NBEC uses in practice and programming. It's incredibly important when talking about maternal health that we apply an RJ lens to meaningfully address the needs of Black women. Another definition that is incredibly important to understand, particularly in today's sociopolitical climate, is birth equity. Birth equity was coined by Dr. Queer Perry as the assurance of the conditions of optimal births for all people, with a willingness to address racial and social inequities in a sustained effort. This means that all people have access to care that is predicated on choice, respect, and autonomy. And this promotes reproductive well-being, which occurs when all people have the information, services, and support they need to have control over their own bodies and to make their own decisions related to sexuality and reproduction throughout their lives. The thing to keep in mind is that because different groups of people have less access to resources, birth outcomes are not equitable in nature. And we see this most clearly with maternal and infant health disparities, where income, wealth, education, and insurance status are not protective factors for Black women. In fact, structural forces perpetuated by racist policies like slavery, the GI Bill, and Jim Crow, which created wealth for many white families, also created inequitable systems of housing, food stability, education, access to care, and safety, all of which have impacts on maternal and infant health. It's important for us to understand that disparities in maternal and infant health outcomes are manifestations of racism, which is the root cause of these disparities. For example, as Dr. Moore just shared, Black women are more likely than white women to live in maternity care deserts and have difficulty accessing comprehensive reproductive health care services. To address these disparities in maternal health outcomes, we use the reproductive justice lens. It allows us to center place, environment, social risk factors, disproportionate burden, and the intergenerational and cumulative effects of structural and systemic racism on maternal health outcomes. Next slide. I actually switched my slides around a few minutes ago. Can you go to the next slide, Christy? Or Sally, thank you. As I mentioned, we use the RJ framework in our policy work and programmatic work across the organization. It requires a robust analysis of the power structures at play, acknowledging that Black and Brown women are subject to intersecting oppressions, that our race, our gender, our class, our neighborhoods, our jobs, our access to healthcare, the criminal justice system, etc., all work together to create the system of oppression that we live in. For RJ experts in the field of maternal health specifically, we know that approaching this work without using an RJ lens is an exercise in futility. With that in mind, I will walk through a few of our advocacy efforts over at the National Birth Equity Collaborative. If you could go back one slide. Thank you. The first thing that we did at NBEC was to develop an agenda that is applied across the organization to promote birth equity. We developed 5 critical measures for ensuring that the United States has the proper infrastructure and resources in place to achieve equitable maternal health outcomes. Number 1 is ensuring that reproductive health and autonomy are promoted and protected at the highest levels of government. Access to reproductive health care of all kinds depends heavily on structural and social factors, where a person lives, how much money they make, and experiences of discrimination all impact the ability to make reproductive decisions. At the federal level, the work of multiple agencies affects reproductive health, and yet those efforts are often siloed, which is why we have called upon the Biden-Harris administration to prioritize reproductive justice. Number 2, health and well-being for all people must be a government priority and a recognized human right. The United States is the only industrialized nation that does not ensure that all people have some basic level of access to health and health care. The COVID-19 crisis drew a devastating picture of how disparities are manifestations of racism and how widespread health and economic consequences affect all of us when public health is deprioritized. Number 3, individuals and institutions should be held accountable for discrimination that leads to disparate health outcomes. The government should support healthcare transformation efforts that include health equity as an explicit goal, are grounded in the needs of communities of color, and seek to provide care that is equitable, trauma-informed, reflective of the healthcare needs of communities of color, and include a fully integrated reproductive health care agenda. The government should prohibit laws, policies, and practices that cause preventable inequalities in health outcomes, regardless of their intent. Number 4, no maternal death should go unnoticed or uncounted. We must systematically account for each life loss and each life almost loss. Despite decades of rising maternal mortality and morbidity, the United States does not collect and disseminate reliable, timely data on maternal health. The government should require and support all states and U.S. territories to collect and disseminate maternal mortality and morbidity data disaggregated by race and ethnicity. And lastly, number 5, the government involvement in reproductive health should not intrude on reproductive freedom, agency, and autonomy, harkening back to the reproductive justice tenets previously referenced. Government involvement in reproductive health can advance human rights by ensuring that all people have access to healthcare services that enable them to prevent and treat illness, experience the best health outcomes possible, and to make the reproductive decisions that are right for them. Next slide. Next slide. Thank you. To this end, we have also promoted models of respectful care. Our cycle for respectful care was recently published in the International Journal of Environmental Research and Public Health. Our cycle of respectful care is based on themes and data collected from Black mothers in cities across the United States for the Mothers' Voices Driving Birth Equity Project, funded by the Robert Wood Johnson Foundation. This work was done in collaboration with our partners at CREOG and the California Maternal Quality Care Collaborative. The idea behind this framework is the answer to what Black women believe respectful care looks like. Themes include accountability, equity, empathy, safety, anti-racism, and trust. The model is deliberately cyclical because the path to respectful care is iterative and has to be replicated at the interpersonal, individual, and institutional levels. We urge all healthcare systems, as well as policymakers, to provide support to implement models of respectful care into practice. Next slide. In March 2020, Congress passed the Coronavirus Aid, Relief, and Economic Security Act, which allocated $15 million to the Health Resources and Services Administration to enhance telehealth and care services for maternal health during the pandemic. The Maternal Telehealth Access Project was funded through a one-year grant of $4 million from the CARES Act to the University of North Carolina at Chapel Hill. UNC engaged 7 collaborative partners, including INBEC, to address the following 3 charges: increasing access to perinatal services and supports via telehealth, increasing capacity of maternity care providers to deliver care via telehealth, and to disseminate web-based information and public service announcements. As a collaborative partner of MTAP, INBEC was charged with carrying out a needs assessment via listening sessions and developing a request for proposals to disperse funds to community-based organizations as part of the implementation phase of MTAP. In this effort, INBEC reviewed 88 applications and dispersed roughly $190,000 to 15 organizations to enhance telehealth infrastructure for maternal health services. The community-based organizations selected to participate in MTAP provided doulas, nurse midwives, and childbirth education services to Black birthing people across the country and territories. From this project, we developed a series of 6 recommendations to increase access to telehealth services, including allocating additional funding to Black women-led community-based organizations to support the delivery of care via telehealth. Sustainable, adequate, and equitable funding streams are necessary to ensure that Black birth workers and community-based Black women-led organizations can continue to serve and make culturally appropriate care available to Black communities. Second, to support trauma-informed racial equity telehealth training for providers. We've already heard Dr. Taylor talk about the importance of telehealth, trainings, anti-racism trainings for providers. And in a global pandemic, this needs to move to an online setting so that more providers can have access to this tool. Third, subsidizing telehealth services for pregnant and childbearing people. As patients continue to shift to telehealth services as an alternative to in-person visits, the inaccessibility of telehealth technologies must be recognized. Fourth, the Centers for Medicare and Medicaid Services should support hybrid models of healthcare by providing guidance, incentives, and promoting telehealth services. By offering hybrid models of care, telehealth, and in-person, women have access to alternative care models and can decide for themselves which avenue of healthcare is most appropriate. Fifth, investing in developing patient record systems that prompt for social service direct referrals when necessary. Robust interoperable record systems can be used to support patients and coordination with continuity of healthcare. And then lastly, embedding a model of respectful care within maternity care quality improvement metrics and tracking quality improvement measures to provide additional accountability mechanisms. Next slide. I'll talk briefly about the HHS public-private partnership led by the March of Dimes, United Healthcare, and the National Birth Equity Collaborative. We convened a Black maternal health stakeholder group earlier this year to provide input on a pilot program led by HHS. The goal of this program is to close gaps in nulliparous term singleton vertex or low risk cesarean birth rates and severe maternal morbidity. We focused on quality improvement in the hospital system and came together to share our vision. Participants in the stakeholder group included maternal health experts from across the field, policy wonks, midwives, doulas, OBGYNs, academics, lactation consultants, mental health specialists, and more, predominantly Black women, came together to discuss our vision. Key themes that emerged from both the pre-meeting survey and during our robust discussions included racism, accountability, data transparency, financial incentives, collaborative, multi-expertise team approaches to maternal health care delivery, systems approaches and policy change, person-centered care, and the centering of Black women's leadership in the maternal health space. We also developed a series of recommendations, including changing relationship dynamics between patients and providers, modification of hospital systems behaviors, and the generation of accurate data that is disaggregated by race. We are excited to see the outcomes of this project over the next year and a half. Next slide. Lastly, I will share our efforts to create a White House Office of Sexual and Reproductive Health and Well-Being. As mentioned in our birth equity agenda, we believe that sexual and reproductive health should be prioritized at the highest offices of government, including the White House. Again, many of the efforts to address maternal health are siloed in nature, and this is a disservice to Black and Brown communities across the country who have historically been barred from accessing the healthcare services we need. There's broad cross-sector support for the development of the office, including support in both chambers of Congress and over 150 different organizations that represent the maternal and child health field and the reproductive justice movement. If established, the office will develop a national sexual and reproductive health and well-being strategy, direct and oversee an intergovernment agency work group on sexual reproductive health and well-being, identify areas of improvement in federal rulemaking and guidance and provide recommendations, and lead public engagement activities, including White House conferences on sexual and reproductive health and public listening sessions. Next slide. There is no one policy solution that will comprehensively address the maternal health crisis, but the recommendations covered by my colleagues today and yesterday are steps in the right direction. Black mothers and Black babies deserve respect, autonomy, and choice. We also deserve access to social supports and benefits that allow us to collectively participate in the everyday joy of life. For too long, too many of us have been underserved by a system that does not value our lives. It's time for our government, our policymakers, our healthcare system, and our healthcare providers to meaningfully meet the needs of our communities by listening to more Black women so that more Black mamas and babies can thrive. Thank you.
Thank you very much, Dr. Godbolt, for giving us this really rich overview of ways we have seen federal public efforts collaborate with private and community partners to address these reproductive health equity issues.